Friends, today I'll be discussing the latest green top guidelines on group B streptococcus. I have simplified it so that using this you can solve any of the questions related to this guideline. So group B streptococcus, it is the most frequent cause of severe infection in the newborn infants. In fact, 50% of the neonatal infection developing within 48 hours of birth is caused by group B streptococcus. So, is universal screening required for group B streptococcus? So the answer would be no. Why is it so? Because first of all, the risk of group B streptococcus infection in general population is very low. It is estimated to be 0.6 per thousand, or in some questions it is also given as 1 in 1750 to 1 in 2000. Also, it has been seen that if somebody is found to be a carrier of group B streptococcus infection earlier in the pregnancy, it is not necessary that she'll be positive for group B streptococcus during delivery, because that is the time when the infection is actually transmitted. Also, if a woman is found to be negative during screening, there are chances that she can get GBS positive during delivery. So, universal screening is not very helpful in this case. What happens to the risk if there is associated intrapartum pyrexia? The risk increases to 5.3 per thousand births. If a woman has GBS in previous pregnancy, then the risk of recurrence is estimated to be 50%. Also, the risk of early onset GBS infection in the newborn in this pregnancy has an increased risk of 2 to 2.5 times, and the risk is estimated to be 1 in 700 to 1 in 800. What are the various clinical risk factors for GBS disease? The postulated risk factors are: if the previous baby had history of GBS, if there is a history of preterm labor, there is preterm rupture of membrane or preterm premature rupture of membrane, or there is premature rupture of membrane, if the mother is a GBS carrier, if there is an intrapartum infection or chorioamnionitis or intrapartum pyrexia. All these contribute to be the risk factors for GBS disease. Now I'll be discussing the various scenarios and whether or not you have to give the intrapartum antibiotic prophylaxis specific to GBS. So if the mother has history of previous baby being infected with group B streptococcus infection, in such a case you have to offer intrapartum antibiotic prophylaxis. And what if there is history of preterm labor, then irrespective of GBS carrier status, or if you know that there is no GBS carrier status, still you have to give an intrapartum antibiotic prophylaxis. Why is it so? Because in such cases, the risk of early onset neonatal group B streptococcus infection is increased to 2.3 per thousand, and the mortality rate is also increased from to 20 to 30%, while in case of term infants, it's around 2 to 3%. What if there is history of GBS and previous pregnancy? So as we have already discussed, the recurrence rate is 50%. So now we have two options. We can either offer IAP or we can offer the bacteriological testing to the female, because all females will not be GBS carriers. So if bacteriological testing is done, it is usually done at between 35 to 37 weeks of gestation, or 3 to 5 weeks prior to anticipated delivery date. For example, in twins, when we are anticipating an earlier delivery, it is usually done between 32 to 34 weeks. If this testing comes out to be positive, then risk is very high, 1 in 400. However, if it comes out to be negative, then the risk is very low, 1 in 5,000. So in such cases, if it's negative, then we can avoid intrapartum antibiotic prophylaxis. What if a female is a GBS carrier? Then definitely we have to offer IAP, because it has been seen that if it is left untreated, then risk of GBS in the baby is 1 in 500. What if the mother has bacteriuria and that is specific to GBS? It is defined as growth of greater than 10 raised to power 5 colony forming units per ml. In such cases, you will treat the bacteriuria and also offer IAP. If there is a planned cesarean, even if mother is a GBS carrier, then you need not give IAP, because the GBS infection is transmitted during labor and delivery, because it forms a normal commensal of the vaginal canal, birth canal. So during cesarean section, the baby doesn't have to pass through the birth canal, so we do not require intrapartum antibiotic prophylaxis. What if there is term rupture of membrane and mother is a GBS carrier? Then you have to offer, because she is a GBS carrier, you have to offer IAP. And in cases of term rupture of membrane, you have an option of waiting for 24 hours, but not in this case. In this case, if you wait, then there is increased risk of transmission of GBS. So in this case, we'll offer intrapartum antibiotic prophylaxis and we'll do induction of labor as soon as possible. If there is a history of intrapartum pyrexia and there is no or unknown GBS carriage, so in this case you will not give intrapartum antibiotic prophylaxis, rather you will give broad spectrum antibiotics. Usually what is given is IV amoxicillin 2 gram every 6 hourly, or we have an alternative of giving IV cefuroxime 1.5 gram every 6 hours in the women with a non-anaphylactic reaction to penicillin. In cases of preterm rupture of membrane, if a woman is more than 34 weeks, then we have to deliver her. We have to give intrapartum antibiotic prophylaxis and we'll do induction of labor followed by delivery. However, if a woman is less than 34 weeks, then we have an option of conservative management. Usually what we give is oral erythromycin 250 mg 4 times a day for a maximum of 10 days, or until the woman is in established labor, whichever is sooner. And once the woman reaches 34 weeks, we do induction of labor and give her a intrapartum antibiotic prophylaxis once she is in labor. What if IUD is there and there is no GBS carrier, with presence or absence of GBS carrier status? So this IAP is given for prevention of infection in the neonate. So if it's already intrauterine death, then you need not give intrapartum antibiotic prophylaxis. So now what do we give an intrapartum antibiotic prophylaxis? Usually benzyl penicillin 3 gram intravenous is given as soon as possible after the onset of labor, followed by 1.5 gram every 4 hourly until delivery. And to optimize its efficacy, the first dose should ideally be given at least 4 hours prior to delivery. What if the patient has penicillin allergy? So it depends, the treatment depends on whether the allergy is severe or non-severe. Severe allergy is classified as presence of anaphylaxis, angioedema, respiratory distress, or urticaria. In such cases, usually we give intravenous vancomycin, which is given at 1 gram every 12 hourly. However, if the infection is non-severe, then we give cephalosporins. Usually we give cefuroxime 1.5 gram loading dose followed by 750 mg every 8 hourly.